Good morning, folks. Welcome to our forum, our spring forum. We're very excited to have you join us today, and I'm going to try and get started, honor all the folks who are on time, but also give an opportunity for others to be joining the webinar. The This program is part of a series of forums that we have here with through our relationship with and funding from New York State, New York City Department of Health and Mental Hygiene, and have an opportunity to introduce you to all of the partners that are bringing this material to you this morning. But first, I want to recognize the associations that have worked together to deliver the program today. I'm from the Home Care Association of New York State. My name is Peter Chernak, and I'm here joined by my colleague and my boss, Al Cardillo, who is the Chief Executive Officer and President of HCA. And I'm just going to ask my colleagues from the Hospice and Palliative Care Association and from the New York State Association of Healthcare Providers to introduce themselves as well.
Good morning or good afternoon, everyone. My name's Jean Chirico. I'm the president
Oh,
of
Gene, I didn't see you there. I'm sorry.
That's okay. I'm president of the Hospice and Palliative Care Association. Thank you all for joining today. Eva?
Good morning. I'm Eva Cohen. I am Director of Regulatory and Community Affairs at the Hospice and Palliative Care Association of New York State. Carol?
Hi, I'm Carol Dio, Director of Regulatory Affairs and Special Programs here at the New York State Association of Healthcare Providers. We have our foundation arm, which does education under this grant funding. We represent home care, and I am thrilled to work with my colleagues once again to bring you this forum.
Thank you, Carol. Let me
Hi,
just move us. Yeah,
hi, I'm Sandy Kern. I'm with HealthQuest Home Care. I'm the Director of Patient Care Services. I'm sorry I don't have a camera available today.
thank you, Sandy. Well, unfortunately we have a huge room of folks, and it would be wonderful to have to hear from everyone. We will have some opportunity for sharing and an open discussion later in the program, as well as responding to some questions that you have after our speaker completes her presentation. But let me go through a little bit of housekeeping and move us forward. We are, the slide moves, there we go. Your audio was muted upon entry, and I'm going to ask you all to keep your audio on mute for the duration of the program. But please add questions that you have or comments that you wish to make into our chat. The chat will be monitored throughout the presentation, and we will be curating that to pose some questions to our speaker and to support and deepen the engagement that we're having on today's subject. The forum will be recorded as well, and we will be sending out to all of the participants a copy of that recording, as well as the slide deck that's being used today for the presentation. And the recording will remain available on the server for 30 days. So you'll have an opportunity to reflect back on this work and to revisit some of what we are presenting this morning. We're looking forward to your feedback, obviously your participation, but your feedback as well. And at the end of the webinar, there'll be an evaluation link and a QR code that we ask you to follow to complete the evaluation. And just to make sure you do, when you actually exit the Zoom platform, you'll receive a SurveyMonkey link at that point as well to go to that evaluation. So we really value the feedback that you can provide for us as it supports our work and our planning for continued programs. So that's the housekeeping end of things. I want to let you know that this is a grant-funded initiative, and we are grateful to the support from the Department of Health and Human Services, the federal government's program for Administration for Strategic Preparedness and Response. And of course, the disclaimer that the content is the view of the authors, does not represent official views of the Department of Health and Human Services. We are thrilled, as we've mentioned already, about our partnership with New York City, with the Department of Health and Mental Hygiene's Office of Emergency Preparedness and Response. And that's been a wonderful source of support for our associations and for our work in New York City, and really helping to provide programming to support preparedness and emergency response throughout the home and community-based sector. I want to offer special thanks to Fidel Monroe, who is the Senior Program Manager at the Long-Term Care Bureau of Health and Community Readiness at the Office of Emergency Response and Preparedness at the New York City Department of Mental Health and Mental Hygiene. She's been a tremendous support of our work and a really wonderful colleague as well. And what happened? Let's go back to the presenting view. Pardon me. Okay. So our agenda this morning, welcome and introductions, which we've begun and will continue to do. You'll then have an opportunity to be introduced to our speaker today, Sam Delanois from NYCEM, from the New York Center for Emergency Management. And she'll be presenting on NYCEM's response planning and resilience. We'll have some questions and answers from NYCEM, from our presenter, and as I mentioned earlier, and then some updates from the Department of Health and Mental Hygiene and from the associations as well. Later in the morning, pardon me, we will have, is it afternoon already? It's noon, right? Later this afternoon, thank you, we will have an opportunity for some open discussion as well. So let me move us ahead briefly. You've met my colleagues from the other associations, and Al Cardillo and myself. My colleague Wendy Parker, I believe, is on the webinar as well. Dr. Parker works with us in our New York City emergency management activity and has been a real support in our work here that resulted in today's program. So welcome, Wendy. And you've met colleagues from the Hospice and Palliative Care Association as well. But you have not yet met, although we've spoken of her, Fidel Monroe. And so I would like to ask Fidel if she could just offer a few words of greeting.
Thank you, Peter. Thank you. Good afternoon, everyone. For those of you who don't yet know me, I'm Fidel Emery Monroe, and I'm the liaison for long-term care emergency preparedness at the New York City Health Department, specifically in the Office of Emergency Preparedness and Response, in the Bureau of Healthcare and Community Readiness, and specifically in the Healthcare System Readiness Unit. And this unit is tasked with the preparedness of the New York City healthcare system, of which you are an integral part. It's my pleasure to be here. I welcome each of you and thank the colleagues from New York City Emergency Management for presenting today. This is the second forum in collaboration with NYCEM that's being held as part of the emergency preparedness programming made possible by those funding dollars Peter mentioned from ASPA through their hospital preparedness program, which is referred to as the HPP program. Activities such as this forum, the tabletop exercises, and other projects are conducted so that your sectors are more prepared to face crises such as the COVID-19 pandemic. Together, as a healthcare system and as members of the New York City Healthcare Coalition, your sectors can test and fortify your plans, policies, and procedures during blue skies, meaning there are no current emergencies, so you're better prepared for gray skies, those times when we are in response mode, when we must band together. The goal of forums such as this is to introduce the sectors, the planning resources in the community that can strengthen your comprehensive emergency plans. Remember those SAMPs? If the New York City healthcare system is to strengthen its resiliency, there must be preparation, participation, and cooperation from providers. Let us meet with each other, work together, share better or best practices and lessons learned, as we will do here today, and incorporate the information into your own emergency planning. I'd like to always acknowledge that the healthcare system in New York City has strengthened with the addition of the home care and hospice and palliative care sectors to the New York City Healthcare Coalition because of your involvement and feedback. On behalf of the New York City Health Department, I'd like to wish each of you a safe and exciting summer 2026. Thank you. Over to you, Peter.
Thank you so much, Fidel, for those words.
You're welcome.
And it's my pleasure now to introduce Eva Cohn, who's the Director of Regulatory and Community Affairs at the Hospice and Palliative Care Association of New York State. And Eva will be introducing our speakers. So I turn it to you, Eva.
Thank you, Peter. So today we are pleased to welcome Sam Delanois from the New York City Emergency Management Agency, also known as NYCEM. Sam serves as a health and medical planning specialist in NYCEM's Health and Medical Unit, where she also serves as an ESF 8 coordinator in the city's Emergency Operations Center. In that role, she works at the intersection of emergency planning and healthcare, coordinating with city, state, and federal partners, healthcare associations, healthcare facilities, and emergency medical services partners to prepare and respond to incidents that impact New York City's healthcare sector. Sam's portfolio at NYCEM includes special medical needs shelters, the burn surge protocol and closed POD plan, and citywide emergency planning and response for health-related incidents. She brings a strong public health foundation to this work, having earned her Master of Public Health from Boston University. Since 2017, NYCEM's Health and Medical Unit has been activated for events ranging from COVID-19 and tropical cyclones to hospital fires, infectious disease outbreaks, and mass casualty incidents. Sam and her colleagues have been at the center of those responses. And today she is here to share what that work actually looks like and what it means for home care and hospice providers who serve some of New York City's most vulnerable residents. Please join me in welcoming Sam.
Hi, thank you for having me. Thanks for the warm welcome and nice background. So as Eva mentioned, I'm here from New York City Emergency Management. I work as a health and medical planning specialist there. And I'm happy to be here today to talk a little bit about what my agency does, what health and medical as a unit does, and how that relates to all of you. So first, as a little background about NYCEM, at NYCEM, our mission statement is that we help New Yorkers before, during, and after emergencies through preparedness, education, and response. We are the city agency that's responsible for coordinating citywide emergency planning and response for all types and scales of emergencies. We are a fairly small department. We're made up of around 200 to 250 dedicated professionals. We all have very diverse backgrounds and areas of expertise, and as well as a number of our team are assigned from other city agencies as well. New York City Emergency Management was formed in 1996, originally as a mayoral office, and then elevated to department in 2001. We were actually located at 7 World Trade prior to moving to our current location at Cadman Plaza East in 2006. This is our lovely building. And our commissioner is Christina Farrell, and our first deputy commissioner is Ben Krakauer. As an agency, we are responsible for monitoring for all potential emergencies, which we monitor for 24/7, 365. We serve as the coordinating agency for citywide response activities, and we coordinate planning, trainings, and drills with federal, state, and local partners. And we also work to increase public awareness and provide community outreach. And I'll go into more detail on all of these functions in a later slide. Our responsibilities and designated roles are specified by New York City's city charter, and ESF 8 being part of NYCEM as well was designated under city charter. As an agency, we follow Citywide Incident Management System, or CIMS. If folks have been in FEMA trainings or in any ICS trainings, you may be familiar with NIMS, or the National Incident Management System, which was created by FEMA, and the city has slightly modified it to suit the specific needs of New York City. And it's really important to our organization and to the city because it provides structure for managing emergency incidents as well as planned events. And under CIMS, roles and responsibilities are established, and we have specific plans as well that we abide by. And it just allows for a more organized, coordinated response as city agencies are clear on what incidents they may serve as a lead agency or a supporting agency when in times of response and activation. So I have a table on this. Hopefully it's large enough, but I've included a sample of incident types and their respective lead agencies on the right. And under CIMS or ICS structure, we have a system for who is the lead of a response. So some activations have a single command. So for example, an elevator incident, the lead agency is FDNY. And that doesn't necessarily mean that no other agencies are involved, but they lead that response. And then other scenarios that are maybe more complex, for example, flash flood would have a unified command. And so the primary agencies are under a unified command. So you have NYCEM, NYPD, FDNY, DEP, and those are all the lead agencies for that response. And as I mentioned, there are plans under all of these that specify their respective roles. But this structure has been really important to the city and has worked very well for us. It was adopted back in 2005 and has most recently been updated in 2022.
Sam, it's Carol. Before you move on,
Yeah.
can I just get you to explain just a couple of acronyms that folks might
Yes.
not know, like DOC, Department
Department
of
of
Corrections?
Corrections. Yeah.
Okay. And then DSS is Social Services,
Yeah. Yep.
and Moya.
Um, oh goodness.
Oh, sorry.
This is no, I just was talking about this yesterday. It's a mayoral office of
Oh, gotcha.
I couldn't tell you right now.
That's
I'm so
that's
sorry.
okay. Just to give folks an idea, some that they may
Yeah.
not ever heard of. And the last one, and I'll leave you alone, is DEP.
Department of Environmental Protection.
Okay, I thought so. I just want folks to
Yeah.
know. Thank you. Sorry.
Sorry about that. Yeah, no.
That's okay. No,
We
it's great.
we say in the emergency management world, it's just like a whole alphabet soup that we are
Oh,
in.
definitely.
So
It's crazy.
yeah,
That's
so
why
I'll
I know the
try.
ones I'm familiar with, and I don't know the ones home care might be familiar with. So I
Yeah.
figured sorry to put you on the spot.
No, that's okay. So I'll try as I go through this to break down acronyms, but if there is something that I haven't spelled out, please, yeah, call me out. Um, and so as an agency, we're broken down into bureaus. So those being community engagement, planning and resiliency, external affairs, readiness, response, logistics, and then support services. Health and medical specifically falls under planning and resiliency, um, and in the interagency coordination branch of this bureau. And we're there with our buddies, human services and critical infrastructure, who we frequently overlap with in responses and activations. Um, so as far as interagency coordination goes, um, we have our watch command, which is staffed 24/7, 365. They're essentially the eyes and ears of the city, and they maintain citywide situational awareness. They do so by monitoring public safety frequencies like police, fire, EMS CAD. They view traffic cameras, they follow news media, social media. They receive direct calls from facilities and organizations, and radio channels, many different feeds that they use to escalate incidents when needed. Um, and then in addition to that, we have our citywide interagency coordinators, or CICs. And they are the folks who they actually head out to the scene when Watch Command gets wind of something. They are sent to the scene, and they provide information back to the agency, to Watch Command and NYCEM, for situational awareness, but also if those folks at the scene do need any sort of resources or information, we as a agency can help coordinate that. And as well as CICs do provide on-site coordination between responding agencies if it is multiple agencies responding. And then we have our Emergency Operations Center, or EOC. And this is the space that is used to coordinate responses to major emergencies, incidents, and events. The EOC serves as a centralized location for decision making, and it allows for more seamless resource allocation and interagency information sharing. Many agencies or healthcare systems may have their own EOC, but the central EOC for the entire city is located at NYCEM's headquarters. Um, and so the way that it works for us, I mentioned that our watch command is 24/7, but the majority of our staff does serve um, as part of an on-call team. So the way that the agency is broken down is that we have 3 teams, red, white, and blue, and each team has a 3-week on-call tour. And then they have 6 weeks off. So we're on for about a third of the year. I'm currently on call. And these on-call tours are 24/7. So that could be 2 a.m. I'm getting a call that a facility is on backup generator power, or whatever the situation may be. They People reach out to me. And on each team, there's roughly 60 NYCEM staff. And specifically for health and medical, we always have 2 or 3 staff that are on call. And this is once again where ICS, if you're familiar, comes in again. Each team has designated folks in each emergency support function, so we have team leadership for each on-call team, staff from our planning unit, our logistics unit, from admin finance, and then the other on-call staff are broken down into ESFs, or emergency support functions, which were once again created by FEMA, and we've adapted them to suit New York City's needs. And so the other emergency support functions are health and medical, human services, public safety, transportation, utilities, infrastructure, external affairs and community engagement, and having these different kind of buckets allow for people, one, to have very specific backgrounds and work responses that pertain to their backgrounds, but also having like centralized point people for those sectors to reach out to. So I work as an ESF 8 coordinator when we're activated under health and medical, and my team is made up of a bunch of folks who have EMS experience. They've worked in hospitals, they have public health masters. Like, we all have a background in that and are knowledgeable in that, as opposed to someone who might be an engineer and working in utilities or some other ESF. And this is a picture of our like part of the EOC, the Emergency Operations Center. I think, yeah, so this is a better demonstration, but basically the way that it's set up is we have our watch command at one end of the EOC, and then you have your sit room, which is basically a big conference room. And then in the middle, you have these rows. And so you have a boat in the middle. That's what we call it. The boat in the middle is where like the ESF coordinators would sit. And then all these arms allow for, if we're in a major response, this one's for health and medical, you would have like FDNY, OCME, Department of Health, like all of the responding agencies that fall under ESF umbrella, ESF 8 umbrella for us, would be sitting physically in the room. And like I mentioned, an EOC is really for that seamless information sharing between agencies, and also to aid in resource requests and just keeping everything moving as smoothly as possible. And what comes with that is our activation levels. So depending on the incident or the event, the EOC has different levels of activation. By design, it's meant to be very scalable. And so at all times, New York City sits in an activation level of 4, which is not the case for all jurisdictions, but New York City has so much going on at all times. So we always have our watch command on and activated and providing situational awareness and for the agency. And then you have level 3, which is for smaller incidents or incidents that maybe only impact a very specific sector. So in this scenario, you would have the sit room open up, and so you might pull in 1 or 2 agency partners or associations to come in and be at the table so that you can have that quick information sharing and in-person response. But then you move up to level 2, which is a partial EOC activation. So you have the sit room, watch command, and then you've opened up the EOC. And so this is for your larger events that that involve multiple different sectors being impacted. And then lastly, you have level 1 activation, which is really an all hands on deck. And really rarely are we ever in a level 1 activation, and it's really reserved for situations like 9/11, Hurricane Sandy, COVID, things like that. It's all hands on deck. Everyone's working and figuring things out. Some of the snowstorms that we had this winter bumped us up to a level 2 response, largely just because of the number of agencies required in like clearing the snow and everything, and transportation, and making sure hospitals and schools and all the essential services that exist in the city are able to continue or muddle through as best as they could. And historically, EOCs have been exclusively an in-person um, operation. But since COVID, for maybe obvious reasons, we were forced to adopt virtual EOC capabilities. And we still try to do majority in person for responses, but we have adapted some of those virtual EOC capabilities as well. They do speed up the rate at which we're able to respond to an incident. Um, you can have the immediate call just on the phone, and then show up in person for the response. So some of these things have been improved with virtual, but as you all probably know, in person is definitely, there are some serious advantages of being able to just walk across the room and catch someone.
And
Uh,
before you move on,
yeah.
I just want to clarify on, so a level two is always enacted, or I don't know what the terminology used, if healthcare is involved. Is that what you said, or did I misunderstand?
It's not always stood up when healthcare is involved. Um, things like this isn't necessarily healthcare, but there was a cyber attack on a blood center last year, and that was more of a level 3 activation. Um, and mostly because it was primarily one sector that was being impacted. So we had the blood banks there, we had the hospital system, we had DOH, all those folks, but people like transportation weren't really being impacted like by that. So I would say that we get spun up a lot quicker when healthcare is involved, which everything like you would be well, you guys work in it, so you guys know. But when I talk to my family, I'm like, you would be surprised by the number of things that impact the healthcare sector. Um, but yeah, so when healthcare is impacted, it does get spun up pretty quickly. But if it is really isolated to just that sector, sometimes it remains at a level 3. And sometimes it's just like a hazmat situation that I'm getting then it's just a level 4, and I'm just coordinating between the state DOH and the facility and EMS and whatever. That's just at a level 4. So it's not always, but
Gotcha. Thank you. And I love the way you just so casually say, if it's just a hazmat incident. I'm like,
well, that's my world.
I know, I love
I'm
it.
like, it's
Thank
just a
you.
hazmat. It's not like a mass casualty. So
Thank you.
bad.
Thanks
But
for letting me interrupt again.
of
So
course.
Sam, can I interrupt for a second?
Yeah.
I just want to summarize something that maybe I heard correctly or incorrectly.
Uh-huh.
So at all times, there's 60 people on a team from NYCEM who are on call and ready to respond to
Yeah.
any New York City emergency.
Yes.
And so it could be the middle of the night. What do you have a bat phone? You have an on-call phone? How do you get activated?
I have an on-call phone that has to
Okay.
sleep next to me or be
Okay.
next to me while I sleep.
Yes,
Um,
that's a health something healthcare workers understand. Yes,
yes,
thank you for that.
exactly. Yeah. So, yeah. Yeah, we do have on-call periods. I wouldn't say like they're they're not call they're not calling me in the middle of the night just to notify me of a fire happening, but if they need questions answered or coordination for a response, that's when they're reaching out to me. Um, but yeah, I do get called in the middle of the night, unfortunately.
Thank you for that.
Yeah. Um, okay. So, health and medical unit. Um, so as I've mentioned multiple times, I'm part of the health and medical unit, and we really focus on incidents that impact the healthcare sector. So we work with local, state, and federal partners, as well as a number of healthcare associations, healthcare facilities, EMS, you name it, in order to plan, prepare, and respond to incidents. Um, this is my crew. as I mentioned, we fall under the Planning and Resiliency Bureau, and our Deputy Commissioner is Heather Reuter. The Assistant Commissioner of Interagency Operations is Johanna Conroy. And under the Health and Medical Unit, we have 5 full-time staff. So that's Rob Bristol's our director, and then we have Sophia, Kayla, Sophia, and Anna as the other full-time staff. Dr. Dario Gonzalez is the medical director for our agency, and he is a Fidney EMS guy. And um, we also have Dr. Anna Levitt, and she's a health and medical fellow that's been with us for the past year or so. And this is a picture of us in the warehouse. So if you're wondering where we are, I'll talk a little bit about this is part of our ChemPack program, which I'll talk about in a little bit. But on a regular basis, we support a lot of planning initiatives. So right now, we're in our annual preparation stages for the coastal storm season, which under that we support the coastal storm plan. This picture is a picture of one of our. I think that this one's actually just it's a picture of a typical shelter, but under the sheltering plan, we support the special medical needs shelters, which I'll talk about in a little bit. And then we plug into the transportation branch part of the coastal storm plan in connection to homebound evacuations. So those operations HEO is the acronym we use for that. So those are the ways we plug into the coastal storm plan. And we also work on a number of other seasonal and weather related plans like flash flood emergency plan, the heat emergency plan, winter weather emergency plan. We all experienced the crazy winter that we had this year. But I specifically for those, I worked 3 or 4 night shifts and numerous day shifts for those activations. And a bunch of my team members also were on that activation as well.
I
And
wonder if I could
yeah.
interject with a question. This is Peter Chernak from HCA. This coastal flood scenario and the activation that you're talking about, and you mentioned homebound folks and the like. Can you talk a little bit about what this level of activation in general, or this kind of specific event would mean for home care agencies and how they might be engaged in a response?
Yeah. So the HEO plan it's incredibly complicated, as I'm sure you can imagine. But it's staffed by primarily FDNY and MTA, like paratransit as well, and a couple of other folks as well. But in terms of evacuation, like the general instruction is that folks are supposed to do their best to evacuate themselves, and there would be lots of communications in terms of like where there are evacuation centers to seek sheltering. But for folks who maybe don't have someone who can assist them in evacuating their space, we do have homebound evacuation operations, and the without going too into the weeds, like there are specific methods depending on like what TAL level the individual is, and essentially it would include having folks assist them from their apartment down to street level, where they would then be transported in paratransit to an evacuation center. And likely, depending on what their health, their medical needs are, um, they would likely be placed either in a special medical needs shelter, which I'll talk about in a minute, or they would be maybe sheltering in a hospital. But in general, I mean, like you can see in this picture, like even though this is just a basic shelter, like shelters are not a glamorous situation. So we're always going to
Yes.
recommend that folks, if they're able to evacuate at like a family member that's not in a flood
Mhm.
zone, or a friend or whoever it may be, that's probably
Mhm.
preferable to the sheltery as well. But we do have like a plan in place to assist with evacuating folks who don't have a support system that's able to help them evacuate.
Mhm.
So,
Okay, thank you. Okay,
yeah.
I'm sure there'll be other questions about that sort of interagency communication and how you go about and FDNY, how it goes about identifying um, individuals in these kinds of situations or other scenarios who are, medically fragile. Of course, if you're a patient in a home care program, in a certified home health agency program, or a hospice program, you're by very definition homebound, if you will. And
Mhm.
so we're working with so many folks who have real medical and social complexity when faced with these sorts of situations. So I just wonder about that communication and the identification and then of course the response. So.
Yeah. I mean, it's very complicated and very situational based. But as you can imagine, like response to a coastal storm and having to evacuate an area, which once again I'll talk about in a minute, but like it's incredibly complex, and just like staffing it alone, using um uh city staff, like we're all stretched so thin during that situation. So it may be collaborative between like the home care association that this person is receiving care from, um as opposed, but like it's very situationally based. And we also, there is some complexities in terms of, as you mentioned, like identifying who's homebound. Folks who are receiving care under like a home care provider, are much easier to identify than folks that may not. Um, it There are some folks that we have data on that say that like all that data is like not very kept up to date. And so it's a very complex program. I'm not directly involved in that one. My colleague Anna is part of that operation and probably can speak on it better. But I just know that it's like definitely something that we are really focused on, and something that we're continuing to improve, how that operation plays out, because of all the complexities. Um,
Sam, we had a quick question about shelters. Are personal care aides and home care aides allowed to accompany a patient to a medical needs shelter?
yeah, so I'll talk about special medical needs
Okay,
shelters in a
sorry.
minute.
Sorry.
Yeah, no worries. Um, yeah, so I'll just, for sake of time, keep on moving to the next slides. But this is what I was talking about when I was talking about how complex the coastal storm evacuations are in numbers. So you guys may be familiar with the Know Your Zone campaign. They had like nice advertisements in the subways and whatnot a few years ago. But essentially, the city has designated flood zones, and zone one is those who are most vulnerable to flooding and coastal storm impacts. And um, New York City has a lot of coastline and a lot of flood zone, and hospitals and nursing homes and adult care facilities have a high likelihood of being in a flood zone. So just zone one alone has 4 hospitals, 22 nursing homes, 17 adult care facilities, and um, like almost 10,000 beds that are going to need to be evacuated. So in addition to homebound evac, you also have hospital evac, and then you have like just your average Joe living in his house that needs to be evacuated. So it's a lot of movement and a lot of complexities in all of that. And heaven forbid we ever made it up to zone 6, where we are then assisting in evacuating 144 facilities and over 32,000 beds. So the zones are like great in terms of establishing who needs to evacuate. But the numbers are very daunting. And so these operations are incredibly complex and very robust. And homebound operations are just a fraction of that. And so it like it's very much a collaborative effort between the public and private sector in assisting folks in making it to whether they're homebound or in a healthcare situation, getting them into healthcare or into a coastal storm evacuation shelter. So in terms of special medical needs shelters, they are set up. So our sheltering system is set up in like a hub and spoke model. So everyone goes to the evacuation center, and then from there they're either directed to a like a basic evacuation shelter, or a special medical needs shelter or a hospital. And so a special medical needs shelter is for folks who have more medical needs than would be supported by than would be supported at like a basic shelter, but not severe enough that they need to spend the duration of the storm in a hospital setting. So special medical needs shelters are ADA accessible. They have special fridges to for medications. They are able to have folks on oxygen. You can have an aide or family come with you to the special medical needs shelter, as well as your pet, or if you have um, a, an animal, why is the word escaping me? Anyways, you can have animals there. We have a pet space. Once again, shelters are not like super glamorous, but it is staffed by health and hospitals, and so they are able to provide like basic medical, like first aid, some medication administration, and there's more assistance there than would be at a typical shelter. If someone does have like very complex medical needs, they're definitely going to end up sheltering in a hospital scenario instead, just purely because of what the shelters are able to support. We do have special medical needs shelters in every single borough. So people would likely would have to travel just within their borough in order to evacuate. Yes, I'll answer more questions at the end just for like the sake of time. I'm going to keep things moving if there are more questions about coastal storm season. Um, in addition to special medical needs shelters, we're involved in a lot of citywide planning efforts, like no notice healthcare facility evacuations. And we have our ChemPack program, which is actually really interesting, especially like essentially what it is it's a federally run program so that people throughout the country are within I think it's a 2 hour radius. Everyone in the US is meant to be within a 2 hour radius of a ChemPack container. And it's a federal program designed to pre-position medications throughout the country um, in order to quickly respond to agents like a nerve agent attack or a biochemical attack. Um, and so we have a number of containers throughout the city, and my team is responsible for maintaining those. We do have two mobile containers or trucks, which is what I have on the screen. And we like send those to mass gathering events like Times Square, ball drop, or um, any sort of parade that's like the Macy's Day Parade or 4th of July. They'll be pre-positioned close by in case anything does happen so that uh, medications could be dispensed very promptly. And in preparation for FIFA, we usually do like an annual sustainment, just making sure all the medications aren't expired and whatnot, and replacing those that are. Um, but we're doing an additional one in preparation for FIFA coming up this summer. Um, and we also work on the burn surge response plan, um, and the CBRN plan. And then my colleague Kayla, she's the WMD program manager, so weapons of mass destruction. So we have all these radiological response and recovery plan, nuclear detonation response plan. She also um, is in the Nuclear Weapon Free Zone and Disarmament Advisory Committee. So there's a lot of that that we work on peripherally, but she's the expert. Um, we work on blood supply surge, so we just had a table talk this week talking about mass casualty events um, where there's a high need for blood products and how that looks and how we're able to sustain care in those kind of scenarios with a focus on blood product supply. Um, and um, Another way that we support the coastal storm plan is healthcare evacuation center operations, or the HEC. That's located at NYCEM's headquarters healthcare when hospitals and healthcare centers are located in flood zones that are predicted to be impacted. There's a whole coordination aspect and operation that goes on and is located at our headquarters. We're involved in a bunch of infectious disease planning, isolation quarantine planning, high consequence infectious disease, regional transport. So last year we just did an exercise that with like a scenario that there was an American in Canada who contracted some sort of high consequence infectious disease and how that would look in all the decon and every step-by-step procedure. So that was very interesting. We do a lot with mass casualties, so notification and response planning. We work with OCME on the mass fatality management planning and with our human services folks and OCME for Family Assistance Center or FAC plans, which the FAC is part of the reunification process for victims and family of in mass casualty situations. Um, and we work with a lot of our EMS partners, so New York City REMSCO and the Quad State EMS Task Force, which now includes Pennsylvania. We used to be the Tri-State. And then some state programs like BioWatch and BioTwig and the New York City Healthcare Coalition, and a number of other efforts. We also work on no notice healthcare facility evacuation. So a few years ago, we coordinated for the Woodhull hospital evacuation. We have our emergency radio communication program where we've pre-positioned radios at healthcare facilities throughout the city, as well as like long-term care, adult care program facilities as well, so that if communications do go down for some scenario, they're still able to reach out to the city for assistance. We run the Healthcare Consequence Management Cell, or the HCMC, which we set up at large events that we anticipate there being a number of patient transfers, for example, like New York City Marathon, and that they were heavily utilized a few years back. If you guys remember, I think it was like 20, I don't know, it was 20, so it was 2019 or so, somewhere around there. Maybe a little bit after, there was one year where New York City Marathon was on a day that was unexpectedly like 85 degrees, and understandably had many patient transports due to heat exhaustion for that. So things like that, we pre-position ourselves in case it's very helpful like that. And then we also support healthcare facility training and exercises. And we have our own medical logs cache at our warehouse as well. And I'm not going to go through all these people, but we are very connected with our partners at a federal, state, local level, and work very closely as well with hospitals, healthcare systems, and healthcare associations as well, which is part of why I'm here. um, and we do a lot of like surveillance and situational awareness work in terms of healthcare system capacity, medical care personnel, medical equipment and supplies, continuity of patient care, behavioral health care, mass fatality management, all of those. And this is just a good visual of like how how you guys fit into this umbrella of health and medical. So in the EOC, depending on the incident, like I mentioned, the EOC is incredibly scalable and fluid in terms of who might be invited to the table, or who's being impacted by whatever the incident is. And so under health and medical ESF includes all of these folks, the departments of health, OCME, FIDNY, ASPER, and then a bunch of like Greater New York Hospital Association. We work closely with health and hospitals, trade associations, home health. All of y'all fall underneath this umbrella of health and medical. And so if you're being impacted, you would be grouped under under that. And I'm gonna breeze past this, but for like as health and I talked about the planning side for a bit, but as like a ESF coordinator, it's primarily like participating in preseason preparedness calls, steering committee calls when an activation is occurring, providing situational awareness emails and bulletins to our partners, coordinating responses and participating in EOC activations and assisting in recovery operations. We also manage the ESF 8 Interagency Teams channel, which we have over 300 users from federal, state, local agencies and healthcare facilities as well. I know a bunch of our DOH folks are on that channel and provide a lot of they amplify our messaging that we post on there as well. And it allows for us to provide pretty immediate situational awareness to the healthcare sector, as well as like receive questions from folks as well. And this is more what I was talking about in terms of what I get called about in the middle of the night is it's usually pertaining to some sort of utility concern or outage or some sort of situation that's occurring at a specific facility. But it could be something much larger. I wasn't on call, so I didn't have to respond too much, but um, my team was called and working through the night on the LaGuardia Airport crash as well. So um, we get pulled into a number of different things. And we also serve as safety officers when members of our agency do get deployed, making sure that they're able to um, respond and maintain their own personal like worker safety and whatnot. Um, and Eva mentioned a number of these, but these are some past incidents that we've responded to and worked in coordination for. Most recently, the NYCEM nursing strike. We participated in, and I mentioned the winter storms. We worked a lot on those and assisted with some of the warming spaces as well, a little bit. H&H Woodhull evacuation, a lot of like last year we were working on avian influenza, the Legionella outbreaks in the Bronx. We've worked on Mpox, COVID-19, and then a bunch of like tropical cyclones, sorry, and hurricanes and whatnot. So we get pulled into a bunch. And just quickly to wrap up, because I want to leave some time for some follow-up questions. But we have a number of public-facing programs. We have our Notify NYC, which we invite everyone to sign up for. It's a great way to get accurate information on what's going on in the city in terms of like weather alerts or any sort of like train outages, stuff like that, things that might be helpful for your situational awareness. We have our Know Your Zone campaign, which I mentioned is how our campaign about flood zones and is really great for folks to be able to identify where they're living, where they're working, and what their risk is to floods and coastal storms based off of their zone. We have Ready New York, which is our community outreach program, and we have a Marvel-esque cartoon called Ready Girl that's for kids. We have our CERT program, which is our community emergency response team, and it's for New Yorkers to get involved in like helping out in incidents and assisting at some of the large events that we work at. And Partners in Preparedness is largely for like schools and other associations to participate in preparedness efforts with the city. And I wanted to mention this specifically for you guys. We have our advanced warning system, which they are emergency alerts for organizations that serve deaf and folks or people with disabilities and others with access and functional needs. There's an AWS app that you can receive messages on your phone about travel advisories, weather alerts, any mayoral declarations, and suggestions for like healthcare facilities as well. There are a number of resources and plans that can also be found on their website and adapted to suit your specific facility's needs. And I can pop a link for this in the chat if that's helpful, but it's also on the slide. I don't know um, what the better way to do that is, but that's pretty much all I have for you guys. Thanks for listening to me talk about what we do. Once again, my name's Sam Delanois. I work in the health and medical unit at NYCEM, and I've included some other emails from health and medical for you guys to, if you have any questions that you think of after the call. But I'm happy to answer any questions now.
Sam, that was really informative. You're getting all thumbs up. I hope you can see the thumbs up and hearts that are flying through here. We didn't have any more questions in the chat. I have asked people to put them in there because we do have time. Um, I think Eva posted the home notify New York City. I know there are so many ways for people to get information. There's that
Mm-hmm.
333 now from New York State. Does that cover New York City too, or no?
Uh,
The 333, 111 or something it's
we
called. What the
do.
hell? I should know what it's called.
I don't think so. That's not something that I've
Okay,
been
never mind then.
made a guarantee.
I thought
Usually,
it was probably outside the boroughs because you guys are kind of separate because you're your own little nation down there.
sometimes it feels like it. Um, we a lot of times for like if there is a major incident that happens, um, 311 is actually our like way in. Like especially for planned events like for FIFA and all of those, like 311 is going to be available. Or if there is a mass casualty incident, we always like knock on wood like crazy at my agency, but heaven forbid that there is a mass casualty. Usually 311 is the way for people to like reach out to the city for things like that. But also our watch command, I can put the watch command number in the chat as well. Like if there is something, they can reach out that way.
That'd be great. And a
Yeah.
reminder to all the attendees that you will get the slides that will have these email addresses um for you to get in touch with Sam if you need to, if you have any other questions, or you can always reach out to any of us at the associations to answer questions. We have another question in the chat, Sam. Um,
Oh, it's
if there's a local power outage and we have clients on LSE, what is the best response? Do we notify 311 and who should we connect with, such as Con Ed?
so for that, I'm gonna put a number in the chat, but I would contact Watch Command because they're gonna be able to escalate it to like if it's a facility level thing, they're gonna be able to um, elevate that to Con Ed. And a lot of times, like in responses, that's like half of what I'm doing, is not necessarily that people don't know what their normal channel is for them to reach out to. Like in the snowstorm, people knew to reach out to sanitations for their ambulance, a street leading up to their ambulance bay not being accessible, but they could reach out to me and I could walk across the room and talk to sanitation and be like, hey, so you haven't been plowing in front of this ambulance bay, like please prioritize that. So things like that like are great for reaching out to Watch Command because maybe they're aware that that area um has an outage, but maybe they aren't, Watch Command might not be immediately aware that you have a facility there. And so that then they can go to Con Ed and say, hey, you really need to prioritize X, Y, and Z place first
Right.
or the other areas. So I'll
Thanks,
pop
Lauren, for the
the
question.
number.
Anybody else have any questions before we move on to updates? This was super informative. I don't know that everybody realizes how many of you are in the background doing all of your things every day to keep everybody safe. It's
I feel
amazing.
like that's healthcare and public health, is if we're doing our job right, no one notices us, right?
Right?
So, yeah. Well, feel free
Okay.
to
Yeah,
send
Sam,
in.
you're welcome to stick around. We're
Okay.
going to have some updates. We have Kim from an epidemiologist from New York City, DOHMH, and then our associations are going to give some highlights. And then we have an open discussion, and you never know what somebody's going to talk about in there. So you're welcome to stick around.
I know Kim. Hey, Kim.
Hey.
I'm not sure if Peter was introducing you or if I could, I'll just roll. I'm going to just
Okay.
roll.
Oh,
If you, yeah, we'll just wait for the slides to settle in. And we're so happy you could join us.
Yes, thank you for having me.
Just waiting for the tech gremlins to get smacked around a little bit. And we'll go back one slide and then we'll
I got nervous when I saw the next slide and thinking, I don't know anything about what that's about. I'll figure it out quickly.
Yeah, we like to do that to our speakers.
I
Just
mean,
throw
why not?
something in there, a random topic, animal husbandry or something. Yeah, why not? Um, so it is my pleasure to introduce Kim, who's become a friend over the last few months as she works with me on another project. So Kimberly Sheldconnect has a master's in public health, a BS in nursing. She's an RN. She is a CDC career epidemiology field officer. Working with the Department of Health and Mental Hygiene for how long, Kim? How long have you been there?
Almost 2 years. It'll be 2 years in July.
Okay, great. They are lucky to have you, and I'm just going to let you take it away, because I don't have your lovely bio in front of me because I wasn't
Oh,
planning on
that
doing
was
this.
perfect. Thank you.
Okay.
You did a great job, Carol. I was having
Okay.
tech problems on my audio side here.
We're here
So,
for you, Peter.
so we'll just say welcome, Kimberly, please.
Thank
Yes.
you. Thank you all. So as Carol mentioned, I work at the New York City Health Department in the Office of Emergency Preparedness and Response and in the Bureau of Healthcare and Community Readiness. So I have a few updates and I don't know if we're doing questions throughout, but go ahead and interrupt if there's questions.
Okay.
I'll start with the respiratory virus season. So first, we're hopefully closing in on finishing it. The respiratory virus season runs from October through May, so we are getting close. And the New York City Health Department reviews the percentage of emergency room visits and hospitalizations that are due to overall respiratory illnesses and then breaks it up separately by influenza, COVID-19, and RSV. And this data is updated every Thursday, comparing it to the previous week and is available on our website. As I go through some of these updates, I will talk about resources and I'll put them all in the chat when I'm done so we can have access to those. So looking at the week, comparing, it's a week lag, so it's comparing to the week of April 4th to the week after. New York City has seen decreases in emergency room visits for overall respiratory virus visits, influenza, COVID, and RSV. But we did see a slight increase in hospitalizations for overall respiratory illnesses, not specific to influenza, COVID, or RSV. And then similarly in New York State, they also have a respiratory virus report that's updated every Friday. And as of April 4th, the state saw slight increases in influenza and COVID-19 hospitalizations and decreases in RSV hospitalizations. And nationally, we are seeing general decreases in respiratory viruses that are requiring people to seek healthcare, whether that's in the ER or in the hospital. And just one thing to note, the RSV season started a little bit later than we expected, and we expect to continue to see activity through the end of this month in many parts of the US. And then just a little bit more about the influenza season. So the influenza A, H3N2 virus are the most frequently reported influenza viruses overall this season. This has been in the news, H3N2 subclade K, and some of why it's been in the news. It drifted or had some small mutation changes compared to the virus that they selected for influenza A as part of this year's vaccine. We do always expect to see these drifts with influenza viruses, and even with that, vaccines do continue to provide benefit against severe illness, death, and hospitalizations. And towards the end of the influenza season, and as we get all the data, we'll know more about the influenza severity and vaccine effectiveness of this season. Any questions about respiratory virus season before we move on to update on measles? Okay, I'll keep going, and if something comes up at the end, we can always come back to it.
Yep, I'm watching for you.
Okay, thank you, Carol.
Sure.
So as of April 10th, there have been 4 confirmed measles cases in New York City. And last year, just for comparison, we had 20 confirmed cases throughout the year. This data is also updated weekly. And so far in New York State this year, there have been 8 confirmed measles cases. So that does include the 4 New York City cases. And last year, New York State had 48 confirmed measles cases. And nationally, as of April 9th, there have been a total of 1,714 confirmed measles cases reported to CDC. And of these confirmed cases, the majority, so 94%, are associated with an outbreak. And 92% of the cases are among people who were unvaccinated or had an unknown vaccine status. And 6% were hospitalized. Just to give you an idea of the increase in these case counts is last year in the United States, we saw 2,287 confirmed measles cases. And that's a pretty significant increase from previous years. In 2024, there were 285 cases. We do have
Did I hear correctly somewhere that we've already had more this year than we had in all of last year? Did you say that? I'm sorry.
No, it's okay. We've had a little over 1,700 this year, and last year we had close to 2,300. So we are on trajectory to exceed last year.
To exceed, yeah, that's what I thought. Thank you.
Yeah. There are a few large outbreaks that are contributing to this. South Carolina had close to 1,000 cases. There's an outbreak in Utah and then also Arizona. Just a little background on why some of this is happening. Measles is very contagious, probably one of the most contagious infectious diseases. And if one person gets measles, up to 90% of the people around them will get it if they're not vaccinated or otherwise immune. And this increasing case count underscores the importance of the vaccine. So the measles, mumps, rubella vaccine is our best protection against measles. And after 2 doses, it offers 97% protection, which is very high. I will link the New York City Health Department and New York State web pages, which not only provide the case count, but information on vaccines. So not only the childhood vaccines, but any additions for travel. Any questions about measles? Okay. And the last thing I wanted to talk about was the upcoming heat season. Seems like we just left the cold, but we are approaching the heat season, and I wanted to share a few resources. Earlier this month, the health department sent out a health advisory to providers on basically resources and reminders of things to prevent heat-related illness and death among patients. I will link this letter, but if providers are not getting our health advisories on the same website, you can also sign up for them. And one of the really important things in the letter, one of the resources, is financial help to cover the cost of an air conditioner or fan for eligible households. Because we find a lot of the deaths in New York City and New York State are due to people not having adequate cooling in their home. The application opened yesterday, and the funding is very limited. So if there's anyone who might benefit from this, we would encourage them to apply. And we also have some just resources I wanted to point out on our website about heat-related illness prevention and also how to locate a cooling center next to where you live. And last, wanted to point out we have a new webpage at the health department on heat and medications aimed at providers. And it talks about how medications can contribute to heat sensitivity, what clinicians can do. And it also gives specific information on drugs that increase the risk of harm on hot days. Any questions about heat or resources or anything else I discussed? I'll put all of these in the chat.
We don't have anything in the chat, but again, like I told Sam, after you're done, you're welcome to stick around as long as you want. We have open discussion, and sometimes a question might come to somebody, 20 minutes from now, and that's why we open the floor up for any emergency management topic. So you are welcome to stick around. We do not have any crackers to serve you, but you're welcome to stay.
Thank you.
Those
Thank you very
resources,
much, Kim.
Yes, thank you.
those
And
resources are great.
yeah, they're terrific. Excellent. Carol, you're actually next up, I believe. So let me advance the slide here. There we go. And perhaps you have some updates for the
I
audience.
I do. And being a pharmacist, I couldn't help but tag on to you, Kim, today, to talk a little bit about flu. I did want to say with heat, it always amazes me that people think about being hot outside. But if I'm not mistaken, most of the heat-related deaths occur because in people's homes that don't have air conditioning. So make sure your folks applied for that assistance. So as far as flu in New York State, we know as home care providers, we have to do a flu personnel immunization report. That report typically opens at the end of April. Last year was April 25th. So that's going to be coming your way pretty soon. We usually have to, thank you, Kim. We usually put out a notification when that opens up, but you do have quite a bit of time to get that report done. You have to report your immunizations for all of your healthcare personnel. Hopefully you've been tracking that all this time. CDC does have some good resources. They're kind of old, but they are still relevant as far as how to track vaccines in your people. Just remember that if you do your flu report like lickety split as soon as it opens, if someone else gets vaccinated, which they still can get vaccinated in May, you're going to have to go back in and revise that report. So yes, you want to get it in early, but no, you might not want to get it in too early. This year, flu was declared prevalent in New York State on December 2nd of 2025, and it was declared no longer prevalent on April 28th of 2026. So hopefully that's around the corner as well, where it will be undeclared and the immunization, the flu requirements for your personnel will be lifted after it is not declared any longer by the State Commissioner of Health. Flu vaccines for next year have already been decided. And they are expected to be of ample quantity to vaccinate anybody who wants them down in the fall. We don't want to think about the fall right now, but that was news that just came out in these last couple of weeks. So I wanted you to know that the vaccines are well underway for next year. The other thing I wanted to talk about is the SEMP, the Comprehensive Emergency Management Program. Now, your SEMP is your Comprehensive Emergency Management Plan. And that is everything that you have that says what you're going to do when before something happens, while something's happening, and after something happens. It's very detailed, and it's often difficult for a small agency to get all that paperwork and all those boxes ticked and all of that. And we have a solution for you. The associations, HCA, HIPCANES, and HCP, worked for a year and a half, 2 years on updating the SEMP to make it applicable to nursing homes or to home care. Excuse me. We took the nursing home SEMP and we rewrote any word that needed to be rewritten and rewrote regulation or included regulations that you guys needed to know to make it suitable for home care. It is a template. All you have to do is fill it out. That is available to you on the Health Commerce System, HCS, which Eva's going to talk about in a second. But then as an added bonus, and not too long after we finished that SEMP, I believe, Eva, it was only a few months from my history I've been doing this morning in preparation for the session. There is an actual training with a bunch of modules that's available on the Learning Management System. And I can put the link in there for that in the chat while one of my colleagues is speaking. If you're not familiar with the learning management system, please get familiar with it. There's so much free information for you there. And one of the things is, how are you going to write this SEMP? So you go on the HCS and you pull the template and the instructions and the toolkit, and you have all of that in front of you. And then you go to the training and you learn, what am I putting where? It makes sense of the process, because it can feel really overwhelming. You do not have to do it all at once. You can do it in little chunks as you get the bandwidth in your day and in your brain. But these are two great tools that New York State offers to everybody. And I really urge you to take advantage of those. And I think that is all I have. Am I turning it over to Eva now, I believe? Eva or Peter? Peter.
Yes, actually, we're saving Eva for last. And we're now going to hear, I believe, from Al Cardillo, who's the president and CEO of the Home Care Association of New York State. And Al, are you there, or
I'm
am I
here.
going to move to Eva?
No, I'm right here,
Okay.
Peter. I'm right here.
Oh, there you are. Excellent. Thank
Um,
you.
Thank you. And again, I just want to thank the prior presenters, everybody for, your engagement in the chat, the questions, and everything, and for your overall participation in this collaborative exercise today in the webinar. I just want to review a few areas where that I would like you to be aware of, and certainly invite your engagement with us to access resources that can be helpful to you. So the first really suite of areas relates to actually webinars that we've done in connection with New York City Department of Health and Mental Hygiene over the past year, which really targeted some areas that are a little bit more unique in the home and community-based space in emergency preparedness. So the first is in mutual aid agreements. And while there has been discussion over the last umpteen years, the mutual aid discussions have generally focused on hospitals and, to an extent, on nursing homes. But home health agencies, hospices, community-based agencies are generally not part of that discussion from a mechanical standpoint. Everybody urges coalition building, but it's different if what you're doing is talking about actively planning to be able to address space. So we had a special session that was conducted by Barbara Citarella, just fantastic, on mutual aid agreements. We're intending to do a lot more with it, but I want to call your attention to it. If we can provide that to you, we're happy to do so. Just be in touch with us, and we can post that. The second is with regard to staff training resources. As the government has been, in this, kind of pause period while trying to determine some of the continued funding, some of the FEMA sites are not accessible. Like ICS is not accessible. But beyond that, really there needs to be a relook and a refresh at training and updating of those basic skills across agencies. There's turnover, but there's also new information and insights that are important to share. And we also did a very comprehensive session noting all of the various resources that are available to you and your staff teams. Finally, another area relates to the requirement for individualized care planning that comes with the federal conditions of participation, and the state regulations mirror those. And those are generally followed for CHAS, for LICSs, for hospices, and for managed care plans as they contract with home care agencies. So again, we did a special session. Barb led that effort as well, that was really focused on the best practices for how you individualize care plans and EP plans for individuals in home and community-based care. Obviously something very unique to our system when compared to the kind of individualized planning one might do if an individual were in a facility. And I think I maybe have a minute to try to wrap up in these next two. I will be quick with those. Also, one thing that is further unique in the home care environment is the fact that everything from authorizations to care management and coordination and case review for Medicaid patients or Medicaid dual patients are done in conjunction together between a provider and an MLTC plan or a PACE plan. And so we also did a presentation. It's a higher level presentation on that partnership, why it's important, and key areas to focus on in the partnering. We are, for the next webinar session that we will do, one similar to this one, we are going to have a facilitated health plan and provider dual presentation focusing on best practices of their partnerships. Last item relates to some of the emerging infections that are on the scene, H5N1, RSV, others that are, very concerning within the process. In addition to those concerns are also the medical complications that can arise as those infections progress to things like pressure injury, cellulitis, UTI, sepsis, etc. We just completed an in-person training on that in New York City earlier this week, and the slides from that will be available to you if you are interested in those. And we will be conducting a follow-up session in May that is focused on direct care workers and what direct care workers need to know about this space. So I wanted to update you on those resources, and once again, thank you all for participating.
Thank you, Al. We're going to move on now to Eva and hear about the work at Hipkanes a bit and some update on from you. Eva, please.
Great. Thanks, Peter. And thank you to everyone who attended today. We appreciate the time commitment that you made. I just want to give what I feel is at least a quarterly update and plug for the health commerce system. Although you get a lot of news from the associations, the first source for New York State updates, including Dear Administrator letters and New York State health notifications, is from the health commerce system. It's a good practice. It's not required, but it is an excellent practice to log in daily. And another a reason to log in daily is because staff changes, and you always need to keep your roles up to date. And your 24/7 contact number, this is a reminder that it cannot be your office. It has to be a phone that is answered 24 hours a day. So I just want to make my plug for the health commerce system. I know everyone thinks that they keep it up to date, but sometimes we go in there and there are names in there that are no longer employed at that agency. So please log in and keep it up to date. And it's a great place to go. The news section is particularly applicable to providers. And then I wanted to just make another plug and maybe an apology that the HERD surveys will continue. We have had some conversation with the Department of Health regarding eliminating, we know they've been reduced, but eliminating the HERD surveys, that's not going to happen anytime soon. And keep in mind that timely completion remains a requirement. And I guess that is a little bit of an apology and a little bit of plug to keep it going. So thank you for everything today, and we will touch base again soon. Peter?
Thank you. We're all continuing our advocacy with the department about those areas of burden that may exist within regulatory compliance. And I understand the implications of Eva's comments about the HERD survey and now SMART form that's being used. It remains a requirement. There are penalties for failing to comply, but we are really looking to advocate for streamlining and for reporting that is relevant, and eliminating some of the reporting that is now perhaps less so. I want to thank our speakers as well. And I just want to say, home care and hospice providers serve patients who are the hardest to reach, the hardest to evacuate, the most vulnerable when the healthcare system itself is under stress. So our role is not a peripheral role, it's a central one. And so I think it's a nice opportunity for us to have some open discussion. I think that, this forum is really truly an opportunity for home and community-based care providers to build relationships and understanding, to network with one another. And that's all part of building a coordinated response. So our open discussion is really just that. And we look to the audience and participants to raise questions or concerns or to share some of what you're doing that you feel interfaces with the emergency response space that we're all about today.
This is my favorite part of every forum. We've done this so many times and we always get such great topics. Um, if Peter, if you don't mind stopping sharing, if folks are welcome to
Oh,
raise
thank
their
you. That
hand.
would be a great idea.
Yeah, yeah, if you guys
There
want to
we
raise
all
your
are.
hand, if you don't want to type in the chat, if you have something to say, there are a lot of you, so we will try to keep an eye on hands or maybe unmute yourself for a second as long as it doesn't get unruly. We can do it that way. Any topics at all. I mean, we can cover any emergency management topics, I ought to say. But and one tidbit I had that I thought of when you were talking, Eva, about apologizing about the burden, and Peter, the burdensome administrative things that we have to do in home care. I heard an amazing statistic once that for every dollar you spend on emergency management, you yield $3 back in return. And imagine if every dollar you spent on record keeping and administrative burden brought you back $4 in return. So, that time we spend doing duplicative reporting and stuff could really be spent on our emergency management plans, which we all need. We are not getting any question. Everybody's quiet today. They're all sitting on their porches because it's beautiful outside. I'm going to take the time then to put in a couple plugs for some things that HCP is doing. We are doing a lot of H5N1 specific projects that also include other infectious diseases. We'll be announcing a tabletop exercise opening soon. That will be a little bit maybe different topics than what you're used to, the same old exercise. So we're hoping to have a little fun with that and learn a lot. And registration for that is going to be extremely limited because it is virtual and we have breakout rooms and we need to make the conversations manageable. So that registration is going to open either tomorrow or Monday. So please watch for an alert coming out for that. It'll come from HCP Emergency Management Alert. We're excited about that exercise. We also have our second webinar in our series, which is coming up in a couple of weeks. It'll be on food safety when you're talking about pathogens and bird flu, and folks say it's in raw milk, what do we do, things like that. I know you guys have projects coming up too, so
Sure. So hospice and palliative care also has a statewide New York City-based scenario exercise for, we call it Operation Novel Plan. That's going to be on April 30th. We are going to just register by email. I'll stick Kim Ryan's email in the chat, but we're very excited about it. At this point, we do have, can't really tell you the scenario because it's supposed to be a secret, but I will tell you that there's that hospices and palliative cares with inpatient freestanding units should all come. Like it is new to us to include our inpatient units in our tabletop exercise, and we can all learn a lot from one another. So that is April 30th for the tabletop exercise for hospice and palliative care providers. I'll put it in the
is
chat.
that virtual or in person?
Well, it is virtual. And it is with a partnership with Incident Management Solutions. Most of you know who they are. A lot of us know who they are. But it's a great exercise. We just had our final planning meeting yesterday, and it is shaping up really, really nicely. It's going to be fun.
Anybody else have any question? Peter, Al, you have other things coming up? I know you gave us a lot of your resources that are permanent resources, I think. And I can't wait for that webinar on the plans and the um, talking about emergency management because it's so important to bring another partner into the mix when one of the problems with home care is that we have to do emergency management, but nobody gives us any money for it, right? And the plans ought to be kicking that up a little bit of a notch.
Yeah, and there's a complexity that relates to the approval of services, who's going to do what when, and one of the things that we often point out is that in the normal scope of things, to the extent that that's already often in an obscure or unsettled situation or just different from a provider plan contract to provider plan contract, you don't have the time to then resort that in an emergency. You've got to be in sync with how you're going to be operating, and so that's trying to really provide more focus on these partnered practices and the effective ones in making this making this happen is a is just a keen focus of ours in trying to work through. Part of it is the fact that there's all sorts of overlapping requirements, between the feds, the state, and requirements as they apply to LICSs, to CHAs, to hospices, to managed care plans, and that sort of has never been really sorted out as the system sort of went from more direct provider to patient enrollment to the inclusion of the health plan networks. And so I think that's a complete unsettled area even in the delivery of care, but in emergencies it becomes especially important. And so again, we're really putting some intense focus on that. We were invited to do a broad presentation on that. We did that both for Central New York, HEPIC, as well as for Marrow. But we would be glad to make those slides available to anybody that could benefit even by seeing what we're describing here at it's a little bit more than the 300-foot level, but a higher level than you're going to get in the presentation that we're going to be scheduling.
Yeah. And do you have any idea when that might come together or when we could look for that or no? I'm not putting pressure on. I'm just curious.
No, that's fine. I mean,
we will, yeah.
Our hope is that would be within the next month.
Nice. Wow.
Our challenge is just simply in the colleagues that we're working with on this for the dates to be nailed down on their parts.
Right.
Yeah, it's hard to get good speakers because they're not available every day.
Well, this is and this is a particularly interesting kind of bringing together of folks from the plan side as well, so for that kind of discussion. So we're really some very wonderful, thoughtful people involved and just finalizing that before we can announce it. So thank you, Al, for sharing that. If we're on the whole area a bit, let me just pause and see if there's anyone from the audience here today that has anything that they would like to raise before we continue on with, important information, but somewhat commercial, I guess,
somewhat commercial.
A bit infomercial.
Yeah, I was just about to ask Billy to put up the evaluation for folks just so they make sure they get it though.
Well,
while we're still
Carol,
talking.
Yeah, Carol, if they leave, they'll get it on exit automatically anyway. So I don't want to, suggest that we're done if we're not. But,
no. I just want to make sure people understand the importance. That's all.
Right. So we have another webinar coming up on April 30th as well, in our series around emerging infectious diseases, and looking at this in this case at best practices in interventions in infection prevention and control, and that's on April 30th. So you'll be receiving emails about that since you're on our lists and such. But we really do look forward to folks joining us across a range of offerings and building capacity around responding to emerging infectious disease and other health-related emergencies as part of our emergency preparedness activity. I'm trying to monitor the chat at the same time. I don't see any hands up per se.
One of the things that we're going to
Can
be
I-
asking you in participating, we have two tabletops coming up, but also in relation to the other webinars, is we're really going to be asking you that if you haven't enrolled in and taken like the basic ICS 100, or some of the other very effective training programs, that you consider doing that. I mean, we're not going to make it a prerequisite before participating, but it would really be very
Yeah,
helpful to do that.
sure.
And if you've not done that to date, I know, like for example, when I'll enter a room, and whenever we're talking this, I'll generally ask how many in the room have done special training or have taken ICS, and maybe one hand will go up in a room of 50 people or 100
It's
people.
amazing.
That's sort of in contrast to times when I'll ask that question and a hand will go up and they'll say, we ask every person in our agency, every single person, to take ICS 100. So
Um,
the benefit of that is that if you haven't done it, the benefit is that everybody gets into the basically the common language and common understanding of a structure that was intended to be in place for any emergency, not just health, but any emergency. And so it also puts you in a position to be able to pivot, because we don't know in an all hazards approach what is going to be the genesis of the emergency. So the extent to which we can all talk to one another, work with one another, avoid doing things that are helpful but really get in the way, is really good training for all of us. So again, I just would encourage that, and we're going to be encouraging that all the more.
That's a great suggestion, Al.
Yeah,
I
I
that
just
that's
added
really
to.
a great suggestion. I want to just pipe in for 1 second because I see Fidel is still here, and in case we lose her, I want to make sure we say out loud how grateful we are for her assistance
Mhm.
and for the New York City DOHMH OPER people, OEPR people,
The
for
Opers.
giving us not only the grant opportunity to do this project, but the additional grant opportunity to work on H5N1 and other emerging infectious diseases, because it's really getting a lot of stuff out to a lot of people that would not otherwise have it. So thank you, Fidel.
Yes.
Sorry, Peter. I just had to do that before we lost her.
No, that's quite all right. And
You're
I hope we
welcome.
never I hope we never lose you, Fidel.
Thank you, Peter.
We are I just put up into the chat the link to FEMA's Emergency Management Institute, which is where you'll find all of the courses, including the ICS 100 course. Unfortunately, you'll find, because of funding right now and until the federal government works out its funding within well, I'm not going to get into all of the
Homeland
the
Security.
the
It's Homeland
language, but
Security.
it's Homeland Security, and under that is FEMA, and within that is the Emergency Management Institute. A tremendous resource of courses, and I encourage you that to keep that link handy and to go there and make use of those resources when in fact it comes back online.
I don't think we have any more questions. If we want to wrap it up and let everybody have a break before their 2 o'clock meetings that they probably have. Um,
That sounds like a wonderful idea.
yeah. So,
And
folks,
I
please,
Yeah,
please
go
don't
ahead.
forget to do the evaluation of the session, because that is, you have no idea how important that is to us. That is the way we plan material that is going to be helpful for you. We don't want the, 5, 6 of us sitting in a room thinking of stuff that you might need when we're not the ones in the field and we don't know what you need. So please do the evaluation. Let us know how we did, how you liked our speakers, and what you need for the future. It's super important, and it really does only take a couple minutes. So that link, I think, will be up shortly. So don't leave without it. And if you do, you'll get it in the email, as Peter said.
Well, you'll get it on the screen in a moment when I share my screen. But you'll also find that when you exit uh, where are we here? When you exit the program, you'll automatically be directed to that link as well. So
Oh,
I'm not
that's
sure if
cool.
you're seeing this or not. Are you?
Yes. Yes, we
Okay,
are.
good. There's the QR code if you want to take a photo of it. There's a link to the Survey Monkey. And again, when you exit the Zoom, the link will appear as well. So we're really
By the
trying
way,
to encourage. Go
Peter, I
ahead.
just wanted to mention I saw going up some accolades from Brielle and other Lauren Campbell and others who we work with in this field, and it's just a fair shout out also to the Department of Health and the regional offices, Megan Cash, the entire group, Nicole, the entire group is really a terrific group to work in. I often will have said that if those kinds of relationships were able to be held and maintained throughout, all that we do together in the delivery system and the government and policy and everywhere else, my gosh, what an incredible system we would have. So I do want to really, really also add our group thanks to the state and regional people, and of course, Fidel. It's incredible to have a nurse in your role. That's just to have someone that really understands this, at the care delivery level is such a privilege. So again, our thanks.
You're welcome.
Okay, folks, please reach out to us if you have any follow-up or want to have an individual discussion or some access to resources that the associations would like to bring to you around this important area. And on that note, I wish you
Have a great
all a
day.
very wonderful day.
Thank you all. Bye-bye.